From Microbe TV, this is Infectious Disease Puscast episode 75, recorded on Wednesday, February 26, 2025. Hello, everyone. I'm Dr. Daniel Griffin, and joining me today is Dr. Sara Dong.
Hi, everyone. I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. How are you doing today, Daniel?
Well, not great, as I think when we get to our viral section, people will realize. These are some pretty troubling times.
Yeah, I feel like my office mate and I just a couple times a day commiserate about something in the news or something relevant to ID that feels like it's not going well.
Yeah. So this will be, well, it'll be a mix. We'll be talking about some troubling things, but we're also going to have some exciting science. So
Yeah. I did hear from some people this week about how they are liking Puscast and have been listening. So that's my positive thing.
Okay, well that's that. Well, in all honesty, I am hoping, right? This is a way for hopefully for people to stay up to date on the literature. Be providing the most up to date evidence based medicine because we spend the time, right? You spend a lot of time, Sara. I spend a lot of time going through, pulling out what we think are, interesting, important articles that might be practice changing, practice improving. So, yeah.
Yeah. Well, as everyone knows, Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. Well, I'm going to start with our viral section. And, please remember to listen to TWIV, both the clinical update, where we throw a lot of our COVID papers in there, but also we talk a lot about the current things that are going on, and also the deep dive, which, continues to be great. But I am going to start off with, I don't know if this is like a public service announcement, an awareness alert, whatever it is, but Vimkunya, what a name. I don't think it's very catchy. Vimkunya, are you going to remember that? It's the new chikungunya vaccine. It's a recombinant vaccine by Bavarian Nordic. We know them well, right, from the Mpox vaccines. There's this. We have this FDA-approved single-dose chikungunya vaccines for persons aged 12 or older who are at increased risk of exposure to chikungunya. So we'll see if that starts being rolled out in the travel clinics across the country. Yeah, and maybe actually getting to places where you're not traveling there, but maybe the people actually living there with a risk.
Yeah. And I basically put a placeholder here. It's not a direct article, but just to talk about the measles outbreak that I know everyone is probably reading about. But there is this large Texas measles outbreak that's continuing to grow. And while it may be that our MMWR type updates are maybe impacted by current events, I think in the meantime, you can look at the Texas Department of State Health Services website. And so their most recent update was 124 cases identified since late January, 18 of which have been hospitalized. Only 5 of the cases were previously vaccinated. And the New Mexico Department of Health also has posted, they have 9 cases because the outbreak's kind of right next to the state border. So those are in Lee County, which I guess is adjacent to Gaines County, which is kind of that main area in Texas where they're seeing these cases. And then it does look like they reported a death in a pediatric patient, which is the first death from measles in the U.S. in many years. So I put links for the Department of Health web pages. But the other thing I was going to suggest while we were talking about Microbe TV is Paul Offit. And I know he's been doing the Beyond the Noise episodes and, giving some perspective on RFK and vaccines and things that have been happening. So if people want to check that out, I think that's a nice way to hear a voice talking about things that you are also probably already thinking about.
Yeah, I'm going to do a deep dive into this when we record tomorrow relative to this, when it drops Saturday, which will be, what is Saturday? Is that May 1st already? Are we getting into May? But thereabouts.
March.
March? Yeah.
Just, let's
Okay.
just skip a
It's
couple
been
months.
so cold. I'm like trying to get to spring. But no, it's
Yeah, March
interesting
1st.
because RFK Jr. made a comment, actually today as we're recording. He's like, yeah, a couple kids have died in Texas.
I
I'm
watched
not
that
aware
video.
there's two, so I hope he's not correct. I'm kind of
They've
preferring
come
to
out and
believe.
said that he was incorrect. Not
Okay.
surprising.
Yeah.
But
I prefer to believe that the head of the HHS doesn't know what's going on than the latter, that another child has died. But
yeah.
yeah, he kind of downplayed it. He's like, this is not a big deal. We're keeping an eye on it. Apparently not a close eye because he doesn't know how many children have died so far. But, really upsetting, right? With measles, I know for RFK Jr., it's statistics. It's, 1 in 1,000, but it's a child, and we're not used to children dying of measles. It's not business as usual. We haven't had a child die of measles in a decade. We haven't seen an outbreak like this in Texas in 30 years. I mean, this is the largest outbreak in modern history here in the U.S. in my career. This is not just okay. We'll keep an eye on it. I mean, I really would like to see. The ability to step in, and not a great time for the CDC to be hobbled and silenced and not communicating and telling us they're only going to give us weekly updates. So at least Texas, said, okay, we'll do Tuesday, Friday, but when this child died, they did update and report on that. So.
Yeah, I've had patients, I'm sure you have too, that are coming in and asking about like if they can get a booster, if they should check their titers, and um anyways, yeah. I
Yeah, no,
think
that's, and the other,
it's not just us
just,
that are worried. Our patients are worried too. Yeah.
yeah, no, and I'm glad you bring that up. And the other thing, just to, usually when something happens like this, the CDC will jump in to help because
hmm
just how many doctors in Texas have ever treated, a measles case before? And they're aware that there actually are some things you do. There's like, certain doses of vitamin A that can have, mortality benefits. And also the other thing, which, really horrific is that, when you get these numbers, we say 1 to 1,000 die, that's during the acute measles. Then you get this immune amnesia, right? Because these are mostly adolescents, and you wipe out their immune memory for all the things that they've gotten in their childhood. And then we see like another, 1 or 2 per 1,000 deaths in the next few months because of that wiped out immune system. So really troubling.
Yeah. Well, I should plug. I totally didn't think about it. There. We did do a febrile episode on measles that people want to listen to, and we're actually working on some episodes on vaccine preventable illnesses because it is unfortunately increasingly relevant.
All right. And Sarah will be putting in links in our show notes. So.
Yeah.
All right. The next we have is timing of influenza antiviral therapy and risk of death in adults hospitalized with influenza-associated pneumonia, influenza hospitalization, surveillance network, flu SurvNet, 2012-2019. That is a long title, published in CID. Basically, what they're looking at is adults aged 18 years and over, hospitalized with laboratory confirmed flu, influenza, and a discharge diagnosis of pneumonia over 7 influenza seasons, 2012 to 2019. So, we have sort of these two diagnoses. You have influenza without pneumonia identified, and you have influenza with pneumonia identified, right? And that with pneumonia identified can either be part of the virus or it can be a secondary bacterial pneumonia. So they looked at this multi-state population surveillance network. They evaluated three treatment groups, right, based on when an individual got that antiviral treatment started. So, you get admitted, and day 0, so like right then you get started on your antiviral. Day 1, so you don't get started till the next day. And then the third group is going to be days 2 to 5, so sort of delayed before the antiviral gets started. A total of 26,233 adults are sampled in the analysis. The median age was 71, and most 92%, which, come on, we're talking about people 71 over, had one or more non-immunocompromising conditions. So they had like other stuff going on. So overall, and I think this is, good. Overall, the majority were started on antiviral treatment right on day one. So day 0 actually is, based on how we do this. Well, the majority is only 60.9% here. Then another, 29.5% on that day one, and then 9.7% on the 2 to 5. But most of those folks are getting started day 2, so 48 hours in. The 30-day mortality really varied on when the folks got the antiviral started. So you did best getting it, on that day 0 when they show up. Mortality 7.5%, 30-day mortality, which is still pretty high. If you then waited, didn't start it till the next day, mortality goes up to 8.5. And if you wait and then another day, so the median here was waiting 48 hours after admission, then over 10% of the patients died within 30 days. So really seeing a huge impact here to start that antiviral. And really, what are we talking about? We're talking about Tamiflu. We're starting Tamiflu on everyone the day they get admitted. Is really going to get, we're seeing here compared to waiting till 48 hours, about a 40% reduction in mortality.
And I realize I'm making up for the lack of viral articles I picked the past couple of weeks because I have a couple in a row. The first two are both from the Journal of International AIDS Society. The first article I have is Mother-Child Dyads Living with HIV in the Western Cape, South Africa. Undetectable equals undetectable? ? So this study analyzed data on mother-child dyads living with HIV born in the window of 2018 to 2022 in South Africa and looked at associations between child and maternal viral load results at the 12 and 24 month mark after the child started ART. There were 2,219 children living with HIV in the group. So it's about a third, 30% diagnosed at birth, 41% diagnosed before age 1, and 29% diagnosed over the age of 1 year old. 90% of those patients were linked to HIV services, but at 2 years, only 43% who had available viral loads were suppressed. And so there were clearly signs here of gaps in care and attrition because many children were missing viral loads. So they found that less than half of the children on ART achieved virologic suppression. And so those numbers, among those who did have an available viral load at 12 months, only 36% were suppressed. At 24 months, it was 43%, and 36 months was 48%. There also were about 5% of children who died, a third of whom had not started ART, but that death data is only available if the children died in a medical facility or were reported some way, so it's likely an underestimate of the actual number. And so children who were more likely to achieve virologic suppression if their mom or mother was also virally suppressed. So I think, again, points to the importance of supporting both in the dyad to achieve virologic suppression, and how, I think, to me, it points that the children are a particularly vulnerable group. And so this second paper I pulled, also just kind of a reflection of seeing what we're hearing about in the news, early impacts of the PEPFAR stop work order, a rapid assessment. And I think the scope of the damage of what is happening with our kind of chaotic new administration is going to continue to grow, but at least this gives some early perspective. As many people who listen to Puscast, I'm sure know, Trump administration issued an executive order in January freezing foreign assistance funds, which includes PEPFAR. There were estimates out there predicting that each day of the freeze, about 220,000 people, including over 7,000 children, would be unable to access treatment. On February 1st, there was a waiver granted allowing some assistance to resume, but it was only for certain activities, and it specifically included things like HIV prevention activities like PrEP. And so the authors surveyed PEPFAR funding recipients in the week immediately following the freeze and stop work order. There were 153 respondents from 27 countries. And so I pulled one of the figures from the paper. Figure 1 shows these disruptions by activity. But just to give an overview, 71% reported complete cancellation of some activities. Most frequently, that was lost to follow-up or re-engagement and care type services. 86% reported that their clients would lose access to HIV treatment in the next month until the freeze is lifted. Over 60% had laid off staff. 3/4 of respondents described severe financial impact. So about 2/3 said that over 3/4 of their funding is from PEPFAR. And 1/3 of the respondents had completely closed down, either temporarily or permanently, with 14% of the organizations reporting that they could not continue operating for more than a month without PEPFAR support. So, I think I thank you to the authors for sharing data on what are huge consequences that it's kind of hard to even wrap your mind around. And I think even if you sort of lift all of these restrictions, we know that a lot of these changes are likely not easily reversible. And okay, in contrast, I know we've kind of started off in a little bit of a bummer, Daniel. I'll turn it
No,
around.
I think it's important for people to realize, like, people are dying every single day. This is not, let's see, give them some time. I mean, people are dying right now. So it's a disaster. I mean, it doesn't matter which political part you are. I mean, I always really respected what G.W. Bush did with PEPFAR. I mean, this was tremendous. He actually was a keynote speaker at ASTM&H one year. And, because he's just a person where in Africa that really just what an incredible amount he did, how many millions of lives he saved. And just to see that destroyed in a matter of weeks. And it's destroyed. So much of this is irreversible.
Yeah. Well, the last thing I picked in our viral section, it actually is a pair of articles, but I'm kind of just going to talk about one of them in the Lancet ID. Its prevalence, clinical management, and outcomes of adults hospitalized with endemic arbovirus illness in Southeast Europe. Mermaids Arbo, which is their...
I figured you'd love
amazing.
it.
I'm going to be totally honest and say that. And that was like a very large reason why I clicked on it. A prospective observational study. So this was, like the title says, prospective observational study of 4 arbovirus seasons, so May to October, from 2016 to 2019. There were 21 hospitals across 7 southeastern European countries. And their goal was describing, like the title says, more information about prevalence and management of selected arboviruses. And so there is a second report that's kind of paired with this on the development and implementation of a serology algorithm. So I put the link to that if people want to follow up. But for this study, these were adults hospitalized with arbovirus-compatible symptoms within 3 weeks of onset. They established how many were due to Crimean Congo hemorrhagic fever virus, CCHVFV, it's not easier to say, West Nile virus, Toscana virus, and tick-borne encephalitis virus. They identified confirmed or probable acute arbovirus infections in 13% of 847 patients who met criteria. Only 45% of those were confirmed locally. And I'll mention that again at the end. But the sort of breakdowns, there's one case of the CCHFV, 16 cases of tick-borne encephalitis virus, 53 of West Nile virus, and then Toscana virus, there were 44. 58% of these patients presented with a meningitis encephalitis type clinical picture. About a quarter had fever with myalgias or arthralgias or similar symptoms. And so they showed some of the expanding geographical range of these infections. So figure 3 is kind of a color-coded map showing case rates by country, with the kind of orange, red colors being higher case rates, so people can refer to those. Fatality was low. There was one death in a patient with West Nile virus, but the infections did impact hospital stays and healthcare burden. These patients were hospitalized for a median of 9 days, and 12% required intensive care. So I thought what was really interesting and important is that there was such an inconsistency between what local clinical labs had versus the reference labs that identified the arbovirus. So arboviruses really were contributing more to adult hospital admissions in these regions than was detected, at least at the time of their admission. Whether that was it's either not available to them or accessible to them, or it just doesn't come back in time to really inform clinical decision making. Either way, they didn't really have that diagnosis at the time they were there. So I thought these were really cool. On top of the fact that mermaids is an excellent, it's an excellent trial name.
I was, the thing I'm looking at is that, well, a couple things I'm thinking. Like, one is I need to go back and like Crimean and Congo, like what's the history of, coming up with that name for this hemorrhagic, fever virus? Because, right, Crimea is that little island just south of Ukraine, and then Congo is down there in Africa.
Yeah.
So, but the other is I was looking at, again, it's a map issue, right? Like everyone's looking at the map and I'm like, well, where's Crimea? We're talking about Crimea Congo fever. And it sort of stops at Romania and doesn't continue east into Ukraine and Crimea. What's going on there? Mm-hmm. How many Americans could draw this map and tell you where, Bosnia and Croatia and Serbia and everything else?
Yeah.
All right. So shall we move into bacterial?
Let's do it.
All right. We're moving into bacterial. That was quite a tour de force there, Sara. So continue to listen. I'll say continue to listen. I'm being an optimist to This Week in Microbiology. Continues to be some really great stuff there. And I will start off with, did I mention site control? AI always forgets about that. So the article, Effects of Extended Anaerobic Antibiotic Coverage on Anaerobic Bloodstream Infection, a Multi-Site Retrospective Study, was published in the International Journal of Infectious Disease. So yes, multi-center, retrospective, observational study conducted in patients with anaerobic bacteremia. And they're going to call it AB. So they performed this to assess the effect of extended anaerobic antibiotic coverage, EAC, wow, these acronyms, on 30-day mortality. So 483 patients were included, of whom 387, so most of them, received extended anaerobic antibiotic coverage, and 96 of minority received limited anaerobic antibiotic coverage, LAC, limited anaerobic antibiotic coverage. It should be LAAC, by the way, but I don't know, maybe it should just be A. So atypical foci of anaerobic infection, such as urinary tract infection and pneumonia, together with undetectable infection foci, comprised a larger proportion of infection foci in the limited anaerobic antibiotic coverage group than that in the extended group, so 46.9 versus 30.5. The 30-day mortality rates for the extended and the limited were similar, 12.5 and 14.2. Not a big p-value difference there. Primary analysis revealed that the extended anaerobic coverage was not significantly associated with high mortality, whereas source control, that was the big one. Source control significantly reduced the risk. And it was pretty big, right? It was like 72% reduction if you actually remember source control, nudge, AI. Maybe now that an AI is going to hear this, it's going to start recommending site control.
I pulled a paper from CID, the effectiveness of newer beta-lactams for the treatment of antimicrobial-resistant gram-negative meningitis. So this article reviews host and drug factors of the newer beta-lactam agents, including cefiderocol, ceftazidime avibactam, ceftolozane tazobactam, imipenem relebactam, meropenem vaporbactam, sulbactam durlobactam, for the treatment of bacterial meningitis. So basically summarizing the data that is available there. They first explain some of the kind of important features of antibiotic pharmacokinetics in CSF, such as CSF fluid penetration and how this doesn't always predict drug concentrations in the brain parenchyma. There's factors related to the drugs like molecule size and lipophilicity, and host factors like the degree of meningeal inflammation. And I actually just pulled this directly because I feel like we talk about that a lot, but I don't think I'd ever had percentages off the top of my head before. So they shared that the percent CSF penetration in the absence of meningeal inflammation was approximately 2% for penicillins, less than 10% for cephalosporins, and 20% for carbapenems. In the presence of meningeal inflammation, those percentages increased to approximately 20%, 15%, and 30% for penicillin, cephalosporins, and carbapenems, respectively. And just for comparison, fluoroquinolone penetration to the CSF was approximately 30 to 70% versus 70 to 90% in the absence or presence of meningeal inflammation. So I thought that was really cool because I think I'd never looked into what those numbers were. So they do recommend using the package insert standard infusion strategies as opposed to prolonged infusions, which may be counterproductive when you're thinking about CSF target attainment. And so they have tons of info in there, but I'm just going to say the bottom line for each drug. So, and kind of in order of preferred option. So preferred option for difficult to treat gram-negative meningitis would be ceftazidime avibactam. Cefiderocol got a reasonable option based on successful case reports. Ceftolozane tazobactam, also reasonable based on successful clinical reports, but it has less CSF penetration data. Ceftazidime avibactam plus aztreonam, as we know, that is preferred for steno and metallo-beta-lactamase producing Enterobacteriales infections, but there aren't really published reports for meningitis. So despite the lack of clinical experience, this is still thought to be a reasonable option. And as we move down, sulbactam, durlobactam, there's some limited preclinical data, but extrapolating from the AMP sulbactam studies, this is likely a reasonable option. And then they recommend against imirelli for unknown CSF penetration. There aren't really clinical reports, and there's a concern for the imipenem seizure risk. And then miravabor, not suggested because there's just not a lot of data, and the clinical outcomes have been mixed. So Table 1 has a really nice overview. I didn't even talk about dosing, but they provide really great references and suggestions for dosing. So when you encounter this, I don't currently have a patient, but I still thought it was interesting to go through. But I put it in a little folder so I can refer to it later.
No, this is a great.
It's really great.
All right. The article, Treatment of Macrolide-Resistant Mycoplasma Pneumonia in Children, a meta-analysis of macrolides versus tetracyclines. So this is published in Pediatric Infectious Disease Journal. And so let's get a little bit, why are we talking about this, right? So, as people may know, we had a quadrupling in the number of Mycoplasma pneumonia cases. We had actually, here in New York, we had a whole bunch of clusters and schools and the rest. The global prevalence of macrolide-resistant Mycoplasma pneumonia infections is on the rise. And so in this article, the authors systematically searched the literature to identify comparative studies that examine the clinical outcome of macrolide and tetracycline antibiotics in children with Mycoplasma pneumonia. They conducted a meta-analysis of the mean duration of fever, hospital stay duration, therapeutic efficacies, time to defervescence, and they're looking at macrolides versus tetracyclines. So which macrolides? Azithromycin and clarithromycin, where the tetracyclines were minocycline and doxycycline. So what is better for that Mycoplasma pneumonia? Put in your bets, Sarah. What do you think? Is it going to be azithro or doxy? So the pooled estimate of 5 studies showed that the mean duration of febrile days and hospital stay was longer in the macrolide group than the tetracycline group. So we've got 1.64 versus 1.22. The therapeutic efficacy was significantly lower in the macrolide than in the tetracycline group. So in the analysis, they basically are going to say the tetracycline treatment is superior to that of macrolide treatment. And did I point out we're seeing an increase in the macrolide resistance rates in Mycoplasma pneumoniae?
As if people need another reason to like doxy.
Well, it is, yeah. I mean, it's kind of amazing. We've seen so much Mycoplasma pneumoniae that
Yeah.
we were talking about it yesterday. I've seen a lot of Mycoplasma IgM get sent. And it really is,
Yes.
this is a woman in the ICU. She probably had heart failure, by the way, just to be complete disclosure. But, acute onset, maybe there was an aspiration event, and they send off, it's within 24 hours of acute decompensate, they send off Mycoplasma IgM. I'm like, guys, remember your biology, right? So like, oh, but the RVP is not that sensitive. I'm like, okay, the RVP is going to be positive when they have the mycoplasma. The IgM, it's not going to come up for 7 to 10 days. So the idea that you're going to like get sick and immediately. So, if we're going to be thinking and seeing more mycoplasma pneumonia, just think about your testing, think about timing and the big impact that has. Yeah. All right. That was me off my soapbox. Let's talk about fungi. This is the best section, right? So we're still waiting. It's almost April. I thought we were going to skip right to May, and then I would have missed the beginning of the new season of The Last of Us. But we have the article, Concordance of Non-Invasive Plasma Cell-Free DNA with Invasive Diagnostics for Diagnosis of Invasive Fungal Disease, published in CID. So retrospective, single-centered cohort study included patients with mold plasma cell-free DNA PCR performed 7 days before or 2 days after invasive specimen collection. Mold PCR detected Aspergillus species, Mucorales agents, Fusarium species, Cetosporium species. Invasive procedures included tissue biopsy and bronchoscopy. The primary endpoint was the concordance of the mold plasma cell-free DNA PCR results with results of conventional fungal tests performed on tissue and bronchoalveolar lavage fluid. And they have this wonderful, I can put on my glasses to look at this wonderful graphical abstract where they go through the study design. They actually show like them sticking needles into stuff. And the concordance, 88.5%. And then when there was any kind of discordance, there was like fungal sinusitis or a limb infection. So really, I think some pretty interesting stuff for mold plasma cell-free DNA PCR.
Yeah. And the paper I pulled was from Intensive Care Medicine, Invasive Fungal Infections in Patients with Liver Disease, Immunological and Clinical Considerations for the Intensive Care Unit. And I think I've talked about this on podcasts before, I'm not sure. But we know that patients with liver disease have complex immune dysfunction. We often meet these patients, and this review specifically was focusing on invasive fungal infections with Candida, Aspergillus, and Cryptococcus in patients with hepatic failure and some unique considerations. But I think actually the best part of it is the way they break down some of the immunologic defects in liver disease. And so they kind of split it up as local and systemic. And so you can see this in their figure 2. It's quite nice. But local, there's impaired microbial filtering. The Kupffer cells, or those local macrophages in the liver, are depleted with liver dysfunction. And this can basically lead to reduced clearance of organisms like Cryptococcus and Candida. And we also know that patients have essentially leaky intestinal mucosa and are at risk for gut translocation. And then systemic, this kind of talks more broadly about immune cell dysfunction, reduced protein synthesis, and how that impacts recognition. So anyways, I thought a nice learning point is that we don't really know if susceptibility to invasive fungal infections is kind of a continuous spectrum, meaning like you have a higher MELD score, your risk is higher, or if there's kind of a threshold effect that at some point you just have a higher risk or you don't. But the rest focuses on the specific invasive fungal infections. It's not as, in the weeds and comprehensive. There's a really nice table. Again, this is the approach in the ICU. So I think this is a really useful resource if you happen to be talking about it to like an ICU team or residents, because it's really meant to be more of kind of like a starter guide. And of course, you guys will be working together on how to modify the therapy and really know what's going on with that patient. But I thought it was a really nice resource. The paper that I had I keep in my little folder for immune dysfunction and patients with cirrhosis or liver disease is like a couple years old now. I might replace it with this one.
All right, parasitic. Be sure to listen to This Week in Parasitism. And I will start off this section with the question: should I move to Texas? Lots of exciting stuff going on there. And here we have the article: Epidemiologic Investigation of Protozoa and Soil Transmitted Helminths in Starr County, Texas, published in the American Journal of Tropical Medicine and Hygiene. And here they conducted a cross-sectional study on an ongoing longitudinal cohort of 616 adults living in Starr County, Texas. A total of 359 adults were screened for 4 protozoa and 5 soil-transmitted helminths by using real-time PCR. The analysis identified 13.4% of the participants tested positive for blastocystis, 0.8% tested positive for Giardia, and 0.3% tested positive for Strongyloides stercoralis. And that person was also co-infected with blastocystis species. Now, infection was significantly associated with age, a lack of health insurance, living outside of a colonia. That was a new one. Apparently, a colonia is a type of unincorporated, low-income slum area located along the Mexico-U.S. states border region that emerged with the advent of shantytowns.
That's really interesting. I would have thought the strongyloides number might have been higher, not based on anything. Just in my head, I assumed it was higher. Interesting.
I feel like it's like we've got areas like what is it, West Virginia? There seems like there's a higher incidence of strongyloides there.
Yeah. And then I have something from CID, post-artesunate delayed hemolysis in African children with severe malaria, incidence, medical impact, and prevention. I attribute my knowledge of originally learning that post-artesunate delayed hemolysis existed from either Twitter or a tutorial, and I will freely admit that. But this occurs in 7 to 25% of adults with severe malaria. There's less data out there on children, hence this paper. The definition they used here was an over 10% drop in hemoglobin level and or an over 10% rise in LDH beyond day 5. This is often mild in adults, although there have been severe cases and complications that have been reported. This association is the clearance of these pitted or once infected RBCs. So once they're killed by artesunate, the Plasmodium falciparum are expelled from the host red blood cell, and it passes through the spleen, which leads to that pitting, basically sort of poking little holes in it, essentially. And then that pitted RBC returns to circulation, but it has a shorter lifespan. So in a couple of days or weeks, when these are all kind of eliminated at the same time, you developed this post-artesunate delayed hemolysis. So of 351 children enrolled in this prospective study, PADH occurred in 76 out of 332 children, or 23%. During follow-up, children with delayed hemolysis were more frequently hospitalized, 11.1 versus 1.6%. They had more frequent, what they called infectious events, 6.9 versus 0.4. More than 2/3 of children received a blood transfusion due to anemia on admission. And when a liberal transfusion policy was adopted, it was associated with a greater than 50% decrease in the incidence of the post-artesunate delayed hemolysis. So I thought this was interesting. I mean, it's a pretty impressive number. That's like 1 in 5 children. It does seem like that high incidence seems to match at least a lot of what has been previously published. But I thought that was a nice article.
All right, and I'll wrap us up with just a couple quick ones here in miscellaneous. And these are just sort of, I think, letting people know. So number one, telehealth, right, which has really been tremendous for infectious disease and during COVID-19, the height of the pandemic. Through March 31st, 2025, you can get telehealth services at any location in the U.S., including your home. But starting April 1st, 2025, you must be in an office or medical facility located in a rural area in the U.S. for most telehealth medicine services. And that's from Medicare.gov. So really, I think like a huge problem. I mean, 80% of the counties in the U.S. do not have an infectious disease specialist, which is really amazing. Board certified infectious disease specialist, all the data we share about how that improves outcomes, all these folks out here that would like to be able to access that care. But it is going away. All right. Public comment, IDSA guideline on management and treatment of complicated urinary tract infections, published 2/19/2025. So I don't know if you're familiar with this, Sara, maybe our listeners are or not, but there's this, what we've got here is the public comment period is now open. And so the ID Society of America has put up this, proposed updated guidelines, and they're now accepting comments on the 2025 updated guideline on the management and treatment of complicated urinary tract infections. This update provides clinical practice guidelines for patients with little c UTIs, with or without sepsis.
I know people have been waiting for this for a long time.
It's complicated, like little c sort of makes it sound like it's, So make sure everyone goes there and comments.
Mm-hmm. Mm-hmm.
It is sort of interesting, right? Like public comments on guidelines. You sort of don't you expect it to be like a room and everyone's read the literature and they go through and discuss and they come up with recommendations with grades. So it's a little interesting here that there's now going to be a public comment period.
Well, Puscast listeners can go and leave their comments. Well, that brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
At least for now, you can grab the Infectious Disease Puscast or Apple Podcast at microbe.tv/Puscast. Grab it on your favorite podcatcher. Watch us on YouTube, right? I should put that on there until they wipe us off YouTube because they're accusing us of medical misinformation. But we love to get your questions, comments, and paper suggestions, so send them to puscast@microbe.tv. If you like what we do or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute, or go to Parasites Without Borders, parasiteswithoutborders.com, and click on the donate button. And I will say, we need your support now more than ever. I was only half joking. Yeah, we are, those of us who are science communicators are actually under attack, and they would like to remove us so that they can have a vacuum to fill with misinformation.
Yeah. Hi, everyone. I'm Sara Dong. You can find me at Sara Wynn Dong or Febrile Podcast on Blue Sky or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as in the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, end dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.